that. Oh, here we go. We're now going to move on to the next presenter, and that is Hamad Rauf, who is a trainee in a urology, a higher trainee in Pindi, around Islamabad area. And he's going to do a case presentation, which hopefully will challenge some of our presenters. So Hamad, the stage is all yours. You have 15 minutes.
Thank you so much. First of all, I would like to thank SIU UK and POS for giving me this opportunity. In my presentation, first I will present a very interesting case. Then I will ask few questions from the presenters. So let me start. 49-year-old female patient, para 3, came with increased frequency and nocturia for 4 times at the night, and she had urge and stress incontinence, and she used to soak 4 pads per day. Initially, conservative management was done, which included pelvic floor exercises and anticholinergic therapies for 3 months, but failed. Then TVT was inserted in another unit for treatment for stress urinary incontinence, but there was no improvement in mixed incontinence, and she was further referred for the management. So my first question to Dr. Rizwan is that, sir, what are the urodynamic predictors of success and failure of TVT sling surgery?
Ahmad, thank you very much for a nice case presentation. I think this is something which we do see quite often, and like you have very rightly said, and we have been also saying in our presentations, that is why urodynamics is very important in pre-operative evaluation of these patients. So you have said on the frequency volume chart, you've got frequency and nocturia. Somebody has put on a TVT, maybe rightly so if she had stress incontinence. But now, as I understand from your case, that the stress component has been cured. It is the overactive component which probably is giving her bother. So in all these cases, the most important thing is the pre-operative evaluation with frequency volume chart and urodynamics. And the urodynamics, the predictors of success for TVT would be that the patient probably has got intrinsic sphincter deficiency, might have hypermobility, but not to an extent with a great cystocele, because if you put a TVT, then you might obstruct her. But in the filling phase of the urodynamics, if there is detrusor overactivity, then in counseling, we tell the patient that we will cure the stress component with this, but the urge component will remain. 50% of chance it might get worse, and hence we need to treat it later on. So that is why the urodynamics predictors for success would be intrinsic sphincter deficiency mainly, maybe some hypermobility, but not a great cystocele, and no overactivity, then your TVT will be successful. If there's overactivity, you can still go on. This is important thing is ask the patient what is a predominant symptom, treat that first, whatever is left can be treated later on, and the urodynamics will point to the direction of counseling.
Right.
Is that answered your question?
Yeah, thank you so much, Dr. Rizwan. So my next question to Dr. Rahila Rizvi. Ma'am, what investigation would you recommend after failure of TVT surgery?
Okay, thank you. And, I appreciate your selection of case, and this is one of the very common scenarios in Pakistan. And to the best of my knowledge, I'm not sure whether somebody has done the urodynamic before even putting in the tape. So I'm very interested to, yeah, I'm sure. So, because you asked the first question, the predictors of success. So if the tape was put in without urodynamic evaluation, so I would just like to know that did you try to, somebody tried to rule out urogenic bladder before putting in tape? Because that's what we do normally, and the chronic diabetes and the things like that, and the overactive bladder diary and the management charting. And now when this is failed, I would like to rule out UTI first, and then I would like to rule out neurogenic bladder. And then we can see what can we do. Thank you.
Thank you so much, ma'am. So, unfortunately, this was done after the surgery. This is the urodynamic study pictures, and this is the X-ray of the patient. Now, I would like to ask Mrs. Solomon, who is a scientist and expert in urodynamic science, and if he's here.
I will answer on Iskandar's behalf. He's having problems logging on. So for those of you who don't know,
can you please comment on the quality and findings of the study, please? I will go back to that.
I will do that. Yeah, thank you. Those of you who do not know, very quick introduction. Iskandar is our clinical scientist. He has got a huge interest in urodynamics and sit on many committees on the ICS also. So essentially, this is a trace of urodynamics, and we'll see the accompanying video later on. This is a very good trace, good subtraction. You can see the filling phase. I'm not sure whether you can see my marker or not. I'm not sharing the screen, but what essentially it shows is that there's an end-filled detrusor overactivity, i.e. once you reach the 2/3 of the line, both the bladder and the vesical lines are going up. So it shows end-filled detrusor overactivity. This is associated with, if you look up in urgency, and like I said in my talk, then this becomes clinically relevant. The capacity is normal. If you look down below in the yellow line, it's filled up to about 500 mils. So that means the capacity is normal. And then if you go to the next slide, please, if you show, one can see that it's got urinary incontinence. And as the bladder neck started below the level of the symphysis pubis, lower margin, that means it's type 2B, stress urinary incontinence, going to the Blavis classification. And you just have to believe that the abdominal leak point pressure was 80 centimeters of water. So can you go back, please? Back to the original slide?
Yes, yes.
Next thing you need to know is the voiding phase. And this is the voiding phase. I don't know whether you can see that. So the patient voided 320 mils. So 320 mils was the void. The maximum flow rate was around 15 mils. And the pressure went up to 17 centimeters of water, 70 centimeters of water. So according to the Abraham Griffiths normogram, it's P dat Q max minus 2 into Q max. So the P dat Q max is 70, and this is 15. So 15 to the 30. 70 minus 30 is 40. So it will be obstructed and left a residue of 180. Thank you.
Thank you so much, sir. Thank you again. So my next question for Professor Nilmi, and
presentation. I think looks quite clearly that she's demonstrating an overactive bladder, and that is her problem really. And the big step would be to really follow all the principles of good continence care. So, you know, looking at her fluid intake, the type of fluids she takes, monitoring that's a starting point. And then looking at the role of physiotherapy, which really people are surprised, but it does help with overactivity because it stabilizes the pelvic floor. Being a woman, the other question is whether she had prolapse, and when you looked at her VCMG findings, you could see there was some prolapse of the anterior wall of the bladder, and that can sometimes create an instability. So that would suggest that actually the physio would help, and it might actually reduce the urgency and the incontinence rate. And if all of that doesn't work, and you'd need to do physio for at least 6 months, you would need to then look at medication and go through the whole pathway that Aaron Sahai spoke through. So look at it step by step by step. There is a big question in some cases like this, whether you should remove the sling or remove the TVT, but that's quite a major operation. So if you can get through it with more simpler techniques, I would probably go down that route.
right.
Thank you.
Thank you. So my next question to Dr. Arun. What are the predictors of response to detrusor overactivity pharmacotherapy?
Yeah. So I think this whole case is very interesting, and thanks for presenting it. I think the key is in the counseling. Once we understand the problem, the patient's got mixed incontinence. I think the counseling is crucial. I mean, she needs to have been counseled, should I say? Sorry, 1 second. I'm just putting my web. Should have been counseled that obviously the treatment that she's had, the TBT, was only going to manage one component of her problem. So if we go right back to the beginning, there would have been good counseling for her so that she would have understood that the TBT is not going to make her dry. It's going to help one aspect of her problems. The fact that they're on pharmacotherapy, this can help. I mean, idiopathic cases like this, there are no sort of classical things. The things to avoid or be concerned about would be, like, for example, poorly compliant bladder, very small capacity bladders. They may not respond as well. But as we know, the urodynamics are done in retrospect. So it's a slightly confusing question for me because we can't predict DO because it wasn't done, if that makes sense. Yeah. Normally in our pathway, as you know, the pharmacotherapy and things, we are managing that without urodynamics. Normally, let's say for OAB, patients will be on medications before we've done the urodynamic study. Traditionally, it's only when they fail medications that they have the urodynamic study, if that makes sense.
Yeah. Thank you so much. And my last question to Dr. Mohammed Bilal. What would you advise the patient if oral agents fail in management of overactive bladder symptoms?
If your medication has failed, I think one of the important things is to use combination therapy. So it's not a simple matter of using anticholinergics. It's in combination with the mirabegron. And once there's failure of this, then the two appropriate, depending on the available resources, would be either intradermal Botox injections or sacral neuromodulation. I think the sort of decision making has to depend on the resources available in that country and also the economic benefit. So sometimes in a developing country, it's very difficult to bring patients back for repeated Botox injections, and the cost of sacral neuromodulation can be prohibitively expensive. Then in that sort of instance, actually, a clamp cystoplasty may be the best cost-effective treatment in the long term. And so I think that decision is, once you've failed the combination therapy, I think you have to take a holistic approach, and depend on the resources available in that particular environment will determine how to manage that. I hope that answers your question.
Yeah. Thank you so much. Thank you, sir. So thank you so much.
Hamad, thank you very much. Well done. And you finished within time, and that always pleases me.
Yeah.
So now move on to our question and answer session. So this is an opportunity for the audience to ask questions to our panelists. And already I have collected several. So let's start with the very first question, which is for Rizwan. Should we do urodynamics before all anti-incontinence? Rizwan.
If you look at the guidelines, they do not recommend that we should do urodynamics for patients who have got pure stress incontinence. But in practice, most of us feel, like the case which Hamad has shown, that patients generally have got some element of overactive bladder. Hence, my practice is, and that of all my colleagues, is that we do urodynamics for all cases when we are suggesting surgery to somebody. So for the initial conservative management, probably urodynamics are not required. Frequency volume chart, clinical examination suffice. But when you offer them surgery, and that also is true for surgery for overactive bladder symptoms, i.e. botulinum toxin or sacral nerve stimulation, then urodynamics should be undertaken. It might be a simple urodynamics without video, but they should be.
On the other experts on this? let's move on to the next question, which is, how do you treat somebody, and this is interesting because it already refers to this case, with somebody with mixed urinary incontinence? What should be the first line treatment? And let's go to Susie on this. Susie?
I think it's, again, going back to what I call the good principles of continence care. So you start off with all the simple things, looking at things like weight loss, fluid intake, types of fluid consumed, and also looking at as much as possible non-additive pharmacological or non-invasive type treatments. And then once you've done that, things have not improved. I would like the role of physiotherapy to come into this as well, so it comes quite early. And if that is still an issue, then the primary approach we usually use is to go for medical therapy, for the overactive component, and see how the patient gets on. Because very often, if you do that combination, you would have treated a significant component of the symptom. At that point, if you find that despite the treatment with the medication for overactive bladder, one can then look at reassessment. At that point, I usually would do an updated urodynamic study with them on medication to ascertain what the situation is, and then look at stress incontinence surgery if required. It's sort of, so it's taking it right back to basics and working systematically through, but keeping it as non-interventionist as possible from a surgical perspective as we can initially.
I request the other panelists to keep your microphone on mute when you're not talking, otherwise, unfortunately, we get a lot of disturbance. So is there anybody else from amongst the panelists who wants to add to what Susie just said?
Yeah, can I just add something briefly?
Yes,
Aaron here. Yeah, so I completely agree with everything Susie said. I think it's sensible in these mixed cases to try non-interventional things, absolute basics. But I would also promote really focusing on the patient history. So whatever bothers the patient the most in a mixed incontinence case, you will be slanted towards treating that first. Obviously, a lot of patients may have equal bother from OAB and stress incontinence, and it's slightly harder. But that is a key component of the history. If one outweighs the other in terms of bother, focus on that in addition.
Any other comments on this from the panelists? If not, can I move on to the next question, which really is for you again, Sunny. Just how many Botox injections should you be giving for refractory OAB? So
the license indication would be 100 units. That is dispensed then in what the license says is 20 injections of 0.5 ml, because the botulinum toxin is reconstituted in normal saline. So that is what is the recommendation from the licensing. Is that what you're asking?
Question. Anybody wants to add anything to that? I mean, I think that's pretty standard. Okay. The other question is, should you stop anticholinergics before carrying out any form of urodynamics? Anybody else other than Sonny to begin with?
That partly is that if you look at the guidelines, there are no guidelines. What all of us try to do is to have one practice. So in our setup, we will stop the anticholinergics before you do that. Oh, sorry, the decision to stop or not stop depends upon what you are trying to achieve. Somebody's got symptoms of overactive bladder, they're not getting better. My preference is to keep them on anticholinergics and then do it so that you know it is not efficacious and you go to the next step. Other colleagues do stop it. There are no right or wrong answer, but my recommendation always is do whatever you do and always stick to that. The same applies to the post-void residue. Do you drain the post-void residue? You do not drain it before you do the test, both for neurogenic and non-neurogenic. For neurogenic, generally, the advice is not to drain. For non-neurogenic, there are no definite guidelines, but whatever your practice is, you should always follow the same practice. Thank you.
Any other comments from the panelists? No? Okay, well, let me just move on, I think, to an equally important topic of training, fellowship training programs. We heard about Pakistan, and I have to say, we all commend what Raheel has been doing. It really is sad state of affairs for a country over 220 million that we just haven't got enough urogynecology specialists. And as I said earlier, there is a bit of a clash there between the urology and gynecologists to actually come to some sort of consensus. So let me ask the panelists here with experience from around the world, what are your thoughts? Can I start, in fact, with Mo? And before I ask Mo this, let me just take this opportunity of introducing Mo Bilal, who will be summarizing the webinar towards the end. Mo is a urologist at Queen Elizabeth in Birmingham. He actually graduated from Cambridge. He did his postgraduate training at Guy's and Bristol Urological Institute. He won the prestigious fellowship, spent time in Australia and Melbourne. He is in numerous clinical trials, and recently he has been elected to sit on the Bowel section of functional urology, so well done. That's quite an important post, and I'm sure you'll make an enormous contribution there, without any doubt, Mo. Mo has perhaps the largest single experience with autologous pubovaginal slings, which are coming back into vogue, as you heard from Susie earlier on. He's also director of the internationally recognized urodynamics course, which I think is the bread and butter of this specialty, and he's been running that for a number of years. He's also the regional lead for sacral neuromodulation. I mean, I could go on talking about Mo a bit more, but perhaps I should stop. And Mo, would you want to just take a few minutes and address the issue of training, particularly fellowship in urogynecology?
Pakistan is certainly at a crossroads, and I think it's very important that the gynecologists and the urogynecologists come together, and it's an opportunity to move the next generation of clinicians to the next stage, and I think it always starts at the beginning with some degree of difficulty, and I think the programs in the UK are now well established, and similarly in America. So I think with that, you can't perform fellowships without the combination of working together. And certainly in Birmingham, we have the Women's Hospital, we have a lot of urogynecologists, and whichever program it is, there's cross-fertilization. The trainee will go to the Women's Hospital and vice versa. So I think with fellowships, it's about having that shared vision. And I think it's really important in Pakistan for people not to see it in terms of territorial, because if you consider the volume of patients in Pakistan of 220 million, there's never a lack of shortage of patients. There's enough patients for all the clinicians. And I think ultimately one has to have the vision that what we are trying to achieve is to improve healthcare outcomes and put our patient at the middle. So, I mean, certainly from the UK, we're very happy to support any program with female stroke urogynecology, because we understand how important it is and how much the population suffers. So I think it's very important that we in the UK engage in Pakistan and other developing countries to help set the services up.
We have Professor Shamim Khan, with whom we had some technical hiccup at the beginning. Shamim, are you there? Now, Shamim, I've already introduced, and he has a lot of experience with teaching and training from around the world, including Pakistan. Do you want to add anything to this, Shamim? Are you there, Shamim? You may be muted. Can you hear us? Shamim, can you hear us? Okay, well, whilst we're trying to get Shamim back on the line, Susie, you've got a lot of experience in setting up teaching and training in emerging world. What are your thoughts about, fellowships specifically in urogynecology?
So in the UK, I am the training program director for Urogynecology at University College London, and have been the director since 2009. And we have taken what we have developed. We developed modular training, so very similar to what my colleagues have spoken about, taking sections, and all of our trainees cross to the different arenas. So they go to urology, they go to colorectal, coloproctology, imaging, they go to physio, they go to all the different units and components of urogynecology, with a view to then having a really holistic training process. They eventually will also produce a few papers which are relevant to the specialty and so on. What I then did was I've worked with the University College of Ibadan, UCH Ibadan in Nigeria, and we set up the same sort of modular program, but taking into account what was available and how we could make it work. Once that program took off and we had our first set of trainees come through, we then applied to the West African College of Surgeons, and it's now part of their routine subspecialty of urogynecology. Now, the difference with obs and gynae in a lot of African countries is that they don't have their own separate college. They're actually part of the surgical colleges. So it's much easier to bring in that integration between all the services. Everybody is part of it automatically. I think what's happened in the UK is we've had this sort of kind of separation between the two, and now we're trying to bring it back together. So I'm trying to work with my urology colleagues at UCLH to try and bring us all together into a singular training program that will eventually, hopefully, I think probably the Americans have the best term for it. They call it female pelvic medicine and reconstructive surgery. So it crosses everything, and I think that will be the way forward. It is very possible. It's very straightforward, but you need an advocate and leader in the field in the host country that wishes to develop it to work closely with. And eventually, to maintain sustainability, you must have academic and professional society buy-in. That's what I found works best.
Can I add something, please?
Yeah, please. Who's that?
No, this is Rizwan.
Rizwan, go for it.
I will agree with everybody else has said. What I want to add is the importance of the multidisciplinary approach, or knowing and working together. So because Susie and I work together, so I can give an example. Let's say Susie is a urogynecologist working at UCH. I'm a urologist working at UCH. We don't know each other. We don't talk to each other. Then it's become very difficult to have an integrated program out to each other. We do not know who the colorectal surgeons are. But we are very lucky. I actually trained with Susie. So Susie and I know each other. We've got nice colorectal colleagues. So what I'm trying to say is that in a hospital, first of all, to set up anything, the trainers need to talk to each other, know each other, work with each other. I go and help Susie with her cases. Susie comes and helps with my cases. So, and with the colorectal, we do cases together. So build up that confidence. And when we go to the MDTs, be it Aachen, be it Ware, Pakistan, Birmingham, we know that by and large, we do the same things. It's just we don't talk to each other. Once we start talking in MDTs, the approach is slightly different, but by and large the same. And then once we have got that confidence, then we get this trainees, this fellowship. So it is a process. Nothing is going to happen within 6 months, but we have to start from the trainers and then work your way downwards. So I think that is what I feel.
I think, Rizwan, that was excellent summary of, in fact, exactly what was going through my mind. It is a multi-specialty approach. It should be pelvic center approach, urologists, gynecologists, colorectal surgeons, working with other specialists who are equally important. So I think, thank you very much for those words of wisdom. Shamim, are you online now? No? I don't know what we've done to upset.
God, he's just washing over.
Yeah, I think he's washing and he's noting, okay? Okay, anybody else on the panel who wants to say any more about I think I want to focus on the training for the next few minutes before we ask Mo to summarize, because I think this is a very important topic. Unless we get the training right, I'm afraid the quality of this service will not improve around the world. Shamim, I can see you. Can you hear us?
I can hear you clearly, but
Okay.
when I switch, can you hear me now?
We can go for it. Do you want to say a few words on the training side of things?
I think I will agree with Mo Bilal. You know, Pakistan is a huge country. There is no problem in getting number of patients. So my take on this, as he rightly said, that we must work in collaboration. Urogynecologists and urologists, we must not compete with each other. We must not work parallel to each other, but join together. And my take on this is that we must establish fellowships in Pakistan because there are plenty of patients. We have infrastructure in different disciplines, and even if we train about 5 or 6 people every year, that will be enough for at least one in each province, or 1 or 2 in each province, who can work as a major centers and then provide the service and educate others. You know, you start from somewhere and then you actually establish a specialty. I know that this College of Physicians and Surgeons, they're trying to establish a fellowship, but they probably don't have the real understanding what they're trying to do, because they need to make sure that this is a discipline which crosses over the boundaries of each other. It is not exclusively female urologists or female urogynecologists. They must work together as a team to subspecialty in Pakistan.
That's great. And can I actually take the opportunity of saying that the host, the Physician Across Continents, is very happy as a charity to take a lead on this. And I think we have the right experts amongst the panelists we have today to help set up, like maybe do a short working paper to approach the college in Pakistan. And I think we can, the timing is right to take this forward and formalize it. So we have a number of champions, Shamim, that we've identified over the years, both amongst the gynecologists and urologists, who are willing to support this.
I mean, the whole idea of this webinar is just a proof of concept. And here we are, we have mixture of urologists and urogynecologists. The whole idea was that we come together and spread this message of unity, that we are working for the same objective, and therefore we must join our forces together to take this forward. So I think it was really a good session. All people contributed, but it's a joint effort to take things forward, not just working against each other, not knowing what others are doing.
Sonny for his comments on this. What are your views, Sonny?
I just want to echo what Shamim and Mo said. I completely agree. I have to say the comments, the recent comments are from Rizwan and Susie as well about pelvic MDT working. It's something that I'm completely familiar with. We have where I work, and is absolute key. I just want to reinforce that message. I think there's a lot to learn both ways. I have to be honest. I've been out to Pakistan myself. I've learned an incredible amount when I went there for a short period in fistula training. So every geography and region has their own unique advantages and disadvantages. And that is something, for example, in the UK, we don't have a lot of access to. But fellowship, I agree, you cannot progress, in my view, without this being set up. I agree with that.
And in fact, I think I have the answer ready. To all the panelists, are we in agreement that we're going to work together, and the host as Physician Across Continents will take a lead on this, with your support, to put a working paper together to see how we can take this teaching and training and the fellowship program forward? Do I have your support?
Absolutely. And there is a lot of good work that's already been done. and we need to actually build on that and build on it with people with like minds. It's a very distinct possibility, easy to achieve. We need to just get on it and work together.
Well, as they say, when we do our appraisal, everyone, it's a smart move, okay? It's doable, okay? So that's great. Now, we literally have 5 minutes left, and I'm going to ask Mo to do a summary. Unfortunately, Mo, apologies, we weren't able to give you the slides of the various presenters, but frankly, I don't think you need them, knowing you.
Thanks to yourself, Professor Mateen.
You mute. That's it, better.
Professor Khan, a big thanks to the organising committee, and also a big thanks to yourself and to Professor Shireen Khan, as well as the speakers, for an excellent session. I have to say it's been pretty fantastic. I mean, Rizwan started off with the importance of assessment and urodynamics. And actually, you know, one of the key take-home messages was the importance of the frequency volume chart and about making the appropriate assessment in the patient. And I think all the centres that don't have urodynamics, I think there should be an impetus to try and set this up. And I think the take-home is how much information one can get from urodynamics and how that helps in terms of treatment of the patients. Susie gave us an excellent overview of incontinence, the causes of incontinence, and has essentially shown us the paradigm of surgery, that essentially some ideas come along and we think it's a great idea, and then we then go back to the old ideas, but obviously with some caveats. And I think one of the key things Susie emphasizes the holistic nature that we need to have an approach. And I think it is very important to have the patient as part of the center of that in decision making. And I think that's really an important take-home message, and certainly sometimes in the developing countries that perhaps is not can sometimes be overlooked. I think Arun has given us an excellent overview about medical therapy, both in terms of combination. And I think one of the take-home messages is not to continue performing anticholinergic cycling, continue giving medication. That's not likely to work. And I think once you've achieved the failure of medication, I think it's important to assess the patient. And I think most would probably agree with in terms of urodynamics, and then to consider the two options depending on what's available, including sacral modulation or Botox injections, both of which are excellent treatment choices. And if failing that, depend on whether you have the expertise to perform a clamcystoplasty or unit diversion. He was very thorough. He went through all the different research trials as well. And a big thanks to our next speaker who actually has brought us to the most important points about training, both in Pakistan and how to set that training up. And I think we're at the early stages of that. And I think the importance is about education awareness, one of the population, but one to the doctors. And with Professor Mateen bringing together the importance of setting up an early working group, we hope that we can use this as a platform to set this up. And finally, I think the case presentations were excellent. It brought home how to manage his patients, and a big thanks to the case presentations, and a big thanks to everyone. So in summary, I think the take-home message are assessment is key, collaboration is key, multidisciplinary team working is key, and I think we can hopefully take this and move this forward. Thank you very much.
Mo, thank you very much for the summary. Can I take the opportunity of thanking the faculty, to PALS International Chapter, to SAU UK, to our sponsor, Getz Pharma, who have been absolutely fantastic in helping us, certainly with the logistics of this. I'm very grateful to the audience. We had 1,640 people that registered. About 300 were actually with us most of the session. We've had a feedback process that started. I'm looking forward to the completion from the rest of the audience, and then we'll send you the formal feedback to everybody at the end. So please do that and give us any other suggestions. And I look forward to meeting up with you all again with another webinar, which will be coming very shortly into the new year. So thank you very much, everybody, and have a lovely, well, rest of the weekend. Thank you very much.